Welcome, and thank you for tuning in to On the Go with CAO, a podcast by the Centers for Advanced Orthopedics. Join us as our orthopedic specialists share their tips and advice for keeping you on the go and in the know, including the latest on how we're treating and caring for injuries and diseases of the body's bones, muscles, joints, ligaments, and tendons. We're here with over 60 offices in Virginia, Maryland, and DC to keep you active and on the go.
Welcome back to On the Go with CAO. We're back tonight. We're going to talk about some shoulder stuff with some of the sports medicine experts here at the Center for Advanced Orthopedics. I'm Dr. Matthew Levine. Try to guide you through what you can expect when you hurt your shoulder. So Chris, when you've got these older patients who come in and they've been having pain for 6 months and they used to play sports, they're having trouble lifting their arm up, and their primary care doctor already ordered the MRI. How do you talk them through the next phase of what they've got?
Yeah, so it depends on what the MRI shows, right? So very different if they just are having some aging of the rotator cuff tendon versus they have a full thickness tear that most people would agree needs surgery unless they're pretty old.
So are there different types of tears? You mentioned a full thickness tear.
Yeah, so the rotator cuff is kind of a broad tendon, so they call it a cuff because it kind of sits on top of the ball. And we talk about the tears in two dimensions, in the width of the tear, so it's how big it is, and the depth of the tear. So the partial thickness means it doesn't go all the way through, and those can be just as painful or more painful in some cases as full thickness tears. And then if it's a really big full thickness tear, multiple tendons, that's a really big tear. So there's those two things. And then it's also, younger patients are going to get their rotator cuffs fixed because it hurts. They can't sleep, they can't do activities. And so almost everybody under 70 or 65 is going to want it repaired. And so then you're doing surgery on them for that. And so then sometimes it's just their biceps is aged and they might just need a cortisone shot, or they might, eventually need bicep surgery, or they have an AC joint. So it really just depends on the diagnosis where you're going to go from there.
Does anybody with a tear, not need something done?
Sure. You could have a massive rotator cuff tear that's old, and you might be relatively functional, even despite the fact that the tear is huge, and maybe someday you'll need a shoulder replacement as a result of that, but you can manage that person non-operatively very effectively for a long time in a lot of cases.
Yeah, I think that, we've talked about before that our job is to keep people doing the things they want to do. So pain and function are our primary guides, right? Those are the two things that we all use to help figure out whether somebody needs surgery or would benefit from surgery rather than needs. So Brion, if you're going to talk to a patient about a rotator cuff surgery, that's a journey that you're going on together.
Correct.
What do patients need to know about a rotator cuff? Forget what size of tear, what shape it's torn, they've failed other treatment options, or maybe they haven't other. What are the things that you want to talk to them about, and what should patients expect when they have that conversation?
I think the first thing going on, what you say is, would you benefit from surgery versus you need surgery? Oftentimes those are the same thing, but sometimes they're divergent concepts. First thing they need to know is that, like everything, this is going to take some time to heal. It's not going to be overnight that you'll be able to go back to doing whatever it was you were doing, whether it's tennis, whether it's gardening and you can't lift up, the 50-pound bag of mulch. So just realistic expectation of the time frame. Secondly, with older patients, if it is the 65, 70-year-old patient that's getting rotator cuff surgery, that it's still typically an outpatient surgery. You don't have to spend any time in the hospital. Now, I think it's pretty common that it's an all arthroscopic surgery, a couple of small poke holes around the shoulder. It's not a big, as some of the older patients say, are you going to cut me open? Small incision, so you don't have to worry about a big, large scar in the front of your shoulder. Then going back to our common theme, it's imperative that you get into physical therapy and participate with physical therapy, both with the therapist and at home on your own. And with the older patients, it's even more critical because they are at risk of developing that stiffness after shoulder surgery and rotator cuff. So reiterating the plan, therapy. Again, we could do textbook rotator cuff surgery. But if the therapy effort isn't there, then they can have a poor outcome.
David, a pleasant 65-year-old female tennis player comes in and she can't serve anymore because it hurts, and she's in her tennis league and she's good and it's what she loves to do. It keeps her energetic, keeps her healthy. It's good for her bones and avoiding osteoporosis because she's doing all these things. And she had her knee scoped last year for her meniscus and she was back playing in a month. Is that what she can get with her rotator cuff?
Well, it depends on what the problem is with her rotator cuff. If it is a full thickness tear that requires a repair, meaning using stitches to reattach the tendon to the bone, she will need to expect a longer recovery. And the 65-year-old who had the meniscus surgery had the meniscus trimmed, had what's called a partial meniscectomy, and that doesn't require actual biologic healing and sealing back together in order to stress the joint. But with the rotator cuff, it takes really 6 months for those rotator cuff tendon fibers to deeply interlock into the bone such that it can withstand her passion of tennis and serving. So if it's a full tear, it's going to be longer. If it's a partial tear, that because as Chris said, a partial tear can be very painful. But if a 65-year-old, the tear is not, if it's less than 50% of the depth, as Chris mentioned, there are a couple ways to measure the tears. If it's less than that, it may just require debridement, or what we do is trim the tendon edges. And if that's the case, it is possible that experience could be somewhat similar to the meniscus surgery the year prior.
But they may not know till you get in there, right?
They may not know, which brings up a great question. Is you have to counsel patients, particularly with partial tears, that may not really know how deep that partial tear is until you're actually assessing it, and they have to be prepared for the longer, because as they make plans and tell their tennis partners, are they coming back for in 2 months or 3 months or 6 months, but that we'll know more right after surgery.
And then Chris, so, we all know this, and I think we all spend a good bit of time talking to our patients. They're going to get their arm numbed up probably with a block for surgery. But rotator cuff surgery tends to be pretty painful. And so what kind of multimodal processes do you use to help them manage pain? What do you tell them to expect? So they're not calling you every day or don't feel like they're in the dark and need to call you every day? What do you tell them so they know that first week to 10 days, what's rotator cuff surgery really going to be like?
Well, so you mentioned the block. The block really has a critical impact on the amount of pain they're going to be in. If they have a preoperative block, meaning before the surgery they get their arm numbed up, the amount of narcotic they're going to use, even after the block wears off, is going to be dramatically less. So by the brain not seeing that level of pain during the surgery, the brain changes immediately seeing that level of pain. So you're going to get a lot less pain medicine. So the block is really critical. I won't do the surgery without it unless there's some compelling medical reasons. So that's one thing. And then modern pain management is multimodal, meaning we're coming at the pain from many directions. So I have all my patients on an anti-inflammatory, and then I have them on Tylenol, and then I have them on some narcotic pain medicine. And so that's kind of modern pain medicine. And then non-medication things that we do, we have them put ice on the shoulder, and that helps. And most of the patients are going to sleep upright for a little while in a chair because it hurts less. And so it is painful. And with the arthroscopics, most patients will tell me that it wasn't as bad as they thought. They had heard such horrible things about rotator cuff surgery, but it really wasn't as bad as they anticipated. So I think we actually do a really good job now of managing their pain, much better than 25 years ago, and that the experience is way better than it was before, and the arthroscopic is probably a big part of that.
Yeah, I think arthroscopic and having sort of experts that stay up to speed on what the newest, proven methods to manage pain and function afterwards. So David, your patient is now 9 months out from their rotator cuff repair, and they're still having some pain. What are your options at that point? What do you counsel them about in terms of the longevity of the repair and when they really get 100% better, when they're going to be as good as they're going to be, and what are options in the future if it's not healed the way, Brian noted that some of these, and we know from the literature, some of these don't heal. Some still have pain, some don't. But what do you tell that patient that's still struggling a little bit, 6-9 months out, about options now and in the future?
So it really depends on the source of the patient's pain. So at 9 months out, when the patient is expecting to be back playing tennis and doing very well, there are a couple of sources. One, it could just be that there's sort of a persistent state of inflammation, that everything has gone beautifully, everything's healed well, their motion is good, their strength is good, but they've gotten back, they're really active, and it's a persistent state of inflammation. So sometimes just offering some reassurance can be helpful, some medication and anti-inflammatory, or perhaps even a cortisone injection, depending on how significant it is. Some patients may not have full range of motion at 9 months. They may have every sign that they've healed well, but they're just a little bit stiff, and they have a little bit of a frozen shoulder, which is not an uncommon problem in general, and not uncommon to work through after surgery. So sometimes it's a matter of kind of working through that frozen shoulder, getting that last bit of range of motion. There's some medications, perhaps even injection that could be considered, and perhaps even additional therapy. And patients can be helpful. The other thing, and I think the thing that's most distressing to patients is, has something happened? Did my rotator cuff not heal? Did I do something wrong? And I think depending on the exam findings and the severity of the pain, sometimes we might at that point get another MRI, and we might want to understand what the problem is. Sometimes patients are doing well, but they may not be aware that many times it takes a year to maybe a year and a half to really get to that place where they're really kind of cruising. So while the patient may be back playing tennis at 6 months, she may not notice the velocity of her serve or really the full strength and comfort. It takes closer to a year and a half before she's like, I'm really 100% back. So I think it depends on really what the source is, and then going from there.
And a lot of that may go back to that original conversation you had with the patient. I think that, telling a patient, it's going to take you a year to really get over this. You're going to have these incremental steps. You're going to walk them through that process, but it's going to take you a year before you're really going to be at that steady state that you described. Now, there are some things along the way that we may have to work through. Sort of as a final topic for us on the shoulders is our colleagues who do hip and knee replacement are the real keepers of hip and knee replacement surgery, but sports medicine is sort of the realm of shoulder replacement surgery. Patients come in these older populations and they've had prior surgery. They were a baseball player when they were younger, and they were in the military. When do you start talking to patients about shoulder replacement, and what's the role of shoulder replacement for the athlete?
So I start talking about them typically if I see that they have arthritis on their x-ray and or MRI, if they have cartilage changes. Not necessarily recommending it at the time, but we start having the discussion and in terms of discussing options. Going back to what you were talking to David about 9 months later, if the rotator cuff surgery either didn't heal or they're still having pain and we get that other MRI, one of the other options at that point is not redo rotator cuff surgery unless you see that what you did healed. Now they have a new tear next to it. You may have a second rotator cuff surgery. But I think there's a large majority in a patient population around mid-50s, 50 years old, that the quality of their rotator cuff tissue is just poor. What you repaired either retore or didn't heal, it's retracted, and then you start talking to them about sort of alternative methods of rotator cuff repair. It's called a superior capsular reconstruction, basically taking cadaver tissue and sewing it into what they have left and trying to recreate what the rotator cuff does by keeping the ball within the socket. I found that is decent. It is somewhat temporizing, meaning you want to give them some pain relief, not necessarily allow them to go back to a heavy duty job or go back to heavy sports participation, but give them pain relief for activities of daily living until they get to that golden age where shoulder replacement.
So you're trying to avoid shoulder replacement.
Trying to
There's some
avoid
options
shoulder
for that.
replacement because there are restrictions and limitations that you advise patients not to participate in. Not a lot of overhead activity, so lots of debate, and I'm sure you've been to several meetings of, if you do shoulder replacement, do you let them play tennis or do you let them play racquetball or
I think that's a really good question for Chris Raffo. So how do you manage? Talk to us about shoulder replacement. They've gotten to that point. They are a little older, but they're active. What can they expect?
So it's interesting because I find that most of the time those patients have given up tennis because they don't have the motion for it anymore. If they're really bad enough for a shoulder replacement, they probably haven't been able to play tennis for a while, and so yeah, there are some, but I mean, it depends on the type of replacement. So there's two kinds. There's what we call the anatomic, which is where you cut the ball off and you put a ball on and you put a plastic socket on the socket. And those patients I will let go back to pretty much everything. The other kind is, so if you have a massive rotator cuff tear or you have a fracture and you have to do a different one, it's called a reverse, and we call it a reverse because we screw in a ball to the socket and then we put a plastic socket on where the ball used to be, and so that type of replacement is a little bit less resilient and a little bit more prone to injury. So those I'd be much less comfortable with. But really, the shoulder replacement patients are a little different. They're coming in because their shoulder is killing them all the time, and they are some of the happiest patients. I mean, everybody loves their replaced shoulder. So when the patients get there, don't be afraid of it. If you're that person whose shoulder is constantly hurting you, when they come in even a month out, they might not be up here yet, but they have a huge smile on their face because their pain that they've been suffering with for 5 years is gone. And so
I think that's absolutely true. For those of us who do shoulder replacement, it's one of the best pain relieving operations that we do, and frankly, the results sometimes are even better than our rotator cuff patients. And letting them get back to do things, they tend to self-regulate themselves. And you're absolutely right that they really love it. So David, knowing that they love it, and let's take our 55-year-old gentleman who's really big and he's been bench pressing 500 pounds since he was age 13, and he just had his shoulder replacement. He wants to know when he can go back, or he's getting ready to have his shoulder replaced. He wants to know when he can get back in the weight room. Do you have different criteria for him than you do for some of the other people?
I do, and unfortunately, this is it's a tough conversation, but. I kind of wanted to say, I tell him that he can't. Well, he can. Everyone will have the choice that they make, but my advice would be that he shouldn't. With shoulder replacement, total shoulder replacement, Chris mentioned that on the socket side, we put a plastic socket on that side. The main mode of failure of a shoulder replacement over time is that socket coming loose. And if you're, a big muscular guy who wants to bench, hundreds and hundreds of pounds, at 55, there's just a really high chance that socket is going to loosen over time. Some people may say, that's okay. If that happens, we'll just deal with it then. I mean, I'm 55. I want to do what I want to do. And that can be okay, but I think, again, it's important to educate the patient about what does that look like at 65 or 70 when you're facing a revision. Everything may turn out just fine, but at the same time, revision surgery, there's an increased risk of infection. So I think it's really important for people to be aware of what the options are, because regardless of what we tell them they can and can't do, should and shouldn't do, ultimately, they'll make the decision and they'll live with it.
Is there anything else that you guys think patients should expect or know or want to learn about shoulder injuries and how we focus on them?
I think it's just important, depending upon their level of function, their expectations, their diagnosis, have the conversation with them to manage those expectations and sort of walk them through the recovery process. And typically, patients will be happy if they can understand the realistic expectation.
One thing that I find exciting and interesting is that we're starting to get some biologics in shoulder surgery now. In particular for the rotator cuff, it's not new per se, but a much more widely available and widely deployed now biologic implant for the rotator cuff that can really improve the healing rates for partial tears. And so hopefully we're going to continue to see that evolve in orthopedics, because we really don't have that much biologics in orthopedics yet. And so the future looks bright there. So.
I was going to say the same thing. I think the techniques are really evolving to help these things that sometimes are, these tissues that are sometimes difficult to heal more reliably and more fully. And so it's a very exciting area of research. The other thing I think patients should know is, a lot of times, whether it's Dr. Google or whether it's talking to friends, a lot of times I feel like I hear people say that, my friend had this done it this way and so, and they returned at this amount of time or had this technique or that type of thing. And I think it's important to know that just because you have a shoulder problem or if you have a rotator cuff problem, these things come in all different shapes and sizes, and we as orthopedic surgeons and shoulder specialists, we try to really tailor it to each specific patient. You can't necessarily lump everyone together with the exact same surgery or technique or recovery.
I think that's a great point. And so, as we wrapped up the knee, we talked about some new evolving technologies, and I think here we've talked about how we've gone to arthroscopic procedures, and now we've got biology coming. I always appreciate having colleagues like you guys to share ideas and thoughts about how we do things, and one of the really great things about Centers for Advanced Orthopedics is that we have a lot of great surgeons that are really on top of their game that we can learn from each other. And so hopefully, we can get back together for another episode of On the Go with CAO in the future and see where things are with the shoulder in another year or two.
We hope you enjoyed this episode of On the Go with CAO and invite you to tune in next time. To learn more about our upcoming episodes or to check out our online library of previously broadcast episodes, please visit cfaortho.com/hub. That's /HUB. Or search for On the Go with CAO on your favorite podcast app. Want to help keep others healthy and on the go? Then please share this episode. At CAO, you'll find over 160 orthopedic specialists committed to providing patients with an exceptional standard of care. The information contained in the On the Go with CAO podcast is for informational purposes only. It is neither intended as rendering medical advice nor as a substitute for seeking professional medical assistance. No relationship between the Centers for Advanced Orthopedics and its practitioners may be created through On the Go with CAO. Any individual with specific questions regarding his or her individual health or treatment options should contact the Centers for Advanced Orthopedics and schedule an appointment with one of its practitioners.